Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith Rogers. Today, how the billions of dollars in opioid settlement funds are being spent. Abby Winiker is an assistant scientist and professor in the Department of Health Policy and Management at the Bloomberg School of Public Health and the program director for the Bloomberg Overdose Prevention Initiative. She talks with me about a project to track these funding spend downs and about some of the expenditures she's seen, from the eyebrow-raising to the truly innovative. Let's listen. Abby Winiker, thank you so much for joining us on Public Health on Call. How are you?
I am doing well, thank you. Thanks so much for having me. It's a pleasure to be here.
So today we're going to talk about opioid settlement funds. But to start us off, would you give us a little bit of an introduction about you and your work?
Absolutely. So I am faculty at the Johns Hopkins Bloomberg School of Public Health, and I am the program director for the Bloomberg Overdose Prevention Initiative. So we are an effort to support overdose prevention, research, and interventions across the country, and part of that work spans some policy oversight related to the opioid settlement funds, which I know we're going to talk a lot more about.
And so tell us about the opioid settlement funds. This is money that is being paid out. How much are we talking about? Who's it going to?
Yep. So a quick background history here, and I'm sure a lot of your listeners are fairly familiar with this, but nationwide, states and local governments have brought litigation against companies along the opioid supply chain. So that includes pharmaceutical companies, distributors, as well as pharmacies, for their blame in the first wave of the opioid crisis. And in 2021, the first national settlement was reached. To date, there have been more than $56 billion promised to states, localities, and tribal governments as restitution funds for those companies' role in the crisis that will be dispersed across an 18-year period.
That is a lot of money. What do we know about how that money is being spent? Where is it going? Who's getting it?
Yes. So let me back up with a tiny bit of context just to sort of explain why I have access to all of these juicy details about where the funds are going. So your listeners may remember that around the end of the 1990s, there were these tobacco master settlement agreements. They were quite similar to the opioid litigation. There were $200 billion promised to states and localities over a 25-year period. And we ultimately learned that less than 3% of that money ever went to sort of cessation efforts or any form of tobacco prevention or risk reduction. So some very smart public health experts saw this opioid litigation fund kind of pooling up and all of this money that was meant to go towards opioid abatement. And we're very concerned that without guardrails in place, these funds would meet the same fate as all of those billions of dollars that were sort of a lost opportunity with the tobacco master settlement agreement. So in response, the team that I'm a part of at Hopkins created a set of principles to guide the use of funds from the opioid litigation. So these were developed with the intention of kind of supporting decision makers to actually use these funds for their intended purpose and ensure that they aren't just lost or sort of absorbed into general funds as the tobacco funds were back in the 90s, late 90s. So all of that to say that my project also involves this major tracking endeavor to identify all publicly available opioid settlement fund expenditures and characterize them into categories of spending. And that tracking project is a multi-agency effort led by myself at Hopkins and then Aneri Patani of KFF Health News and Kristen Pendergrass at Shatterproof. This is a major undertaking. It involves a team of about 10 to 15 people looking at every state and every locality to find any publicly available information on where these funds are going. And I will just note that there are no sort of standards for reporting in place across the country. So that makes it a very tricky project and major endeavor, but it does allow us to really gain some powerful insights into where this money is going.
I would imagine that you see some very innovative ways, and maybe you see some things that are probably maybe not what that money was intended for. So give me the good, the bad, and the ugly. Let's start out with some tactics that maybe made you wince a little bit when you saw them.
Sure. So there are unfortunately a lot of sort of eyebrow-raising expenditures. I wish there were less, but I think what sort of rings the alarm bells across the public health experts who are involved in trying to keep track of where this funding is going the most quickly is spending on law enforcement. And that's not all spending on law enforcement, but there are millions of dollars of these funds that are going to things like police surveillance technology, weapons or guns, drones. In one state, settlement funds were used to pay for a shooting range. These are all things that are linked to a punitive and enforcement-based response to addiction that, decades of research show are ineffective and, in fact, cause more harm. So these are really counter to the sort of intention of these funds, which is to abate the harms of the crisis.
So maybe give us an example of something that you thought was a little, random.
Yes. Yeah, there are many random items as well. Some things under the prevention umbrella often strike us as falling into that random category. We have one expenditure for a D.A.R.E magician. Now, D.A.R.E is the Drug Abuse Resistance Education Program. We know that there is no evidence to support the effectiveness of this particular intervention. Hard to imagine how adding a magician to the curriculum would necessarily increase the effectiveness, but that was a random one. There was one state that used settlement funds for a sock hop event, at the end of which attendees were asked to pledge to remain drug-free. And one final one that I get a chuckle out of every time is an expenditure that was simply labeled as lollipops, no drugs. Presumably, whatever the opposite of drug-filled lollipops, these were the drug-free lollipops.
Wow.
Yeah.
Okay, so I imagine that you probably spend a little bit more of your time helping to give people good ideas. So let's get into some innovations that you've seen or maybe that you've helped work on that you think are truly exceptional.
Yes, thank you for that question. So my team at Hopkins held an event in late March with the Center for Mental Health and Addiction Policy with the sole intention of really elevating some innovative examples of settlement fund spending. And we have put out a resource document alongside this event because we think it's really important to not only draw attention to these sort of negative uses of funds, but also highlight and elevate the best practices and those things that are really using evidence and much more likely to follow the intent of these settlement funds, which is to abate the harms of the crisis. So I have many to highlight, and I will try to pare it down to just a few examples, but we have lots more information too available on our settlement website, which I will just plug now as opioidprinciples.jhsph.edu.
So let's talk about some of these innovations.
Yes, I would love to. The first thing that we highlighted, which I think is a really powerful program that we've seen across several jurisdictions in the country, is something we call field-based emergency medical service delivered buprenorphine induction. And I realize that is a lot of words and a lot of technical jargon, so I'm going to try to break it down. Listeners are likely familiar with naloxone. That's the medication that reverses an overdose. It's a super effective way to save lives. But because of the mechanisms through which naloxone works, it also leaves someone who has received naloxone in a state of very painful withdrawal. And this is a very agonizing physical experience that we know often leads to reuse and sometimes to re-overdose. So one way to treat that withdrawal is through the administration of buprenorphine. That is an FDA-approved medication that is used to treat opioid use disorder. And research shows that it's actually a best practice to get someone onto buprenorphine right after an overdose reversal. So some places have created these super innovative programs where their EMS staff actually start people that they've just revived on that medication in the immediate aftermath of an overdose. And this is an incredibly effective way to meet people where they're at, reduce overdose risk, and then has a lot of additional benefits like linking people to further treatment in the longer term. People who are inducted onto this medication in the field are much more likely to sustain treatment in the longer term.
So in other words, EMS that is responding to an overdose that's happening, like say on a sidewalk somewhere, they administer the naloxone, the overdose is reversed, and at that moment they offer them the buprenorphine?
They do, yep, and they can do it right on their ambulance. So they have the medication on hand and they can transition them right onto that medication, which will get that person out of withdrawal and is very likely to keep them from using again and reduce that risk of re-overdose. And then once someone is out of withdrawal, they're much more likely to be willing to be connected to other care services. And so it really serves as a linkage to a lot more treatment and recovery mechanisms as well.
All right, let's talk about another innovation.
Another thing that we find super innovative and really valuable right now is community-based drug checking. We know that the illicit drug supply is highly volatile. That means that when someone goes to buy heroin, for example, what they often get these days is a mixture that includes many substances. Ironically enough, they often don't get any heroin at all these days. Some of the common adulterants that we hear about include things like tranquilizers. Your listeners may have heard about xylazine or tranq. These are animal tranquilizers that are definitely not meant for human consumption. And then there's things like psychedelics, which lead to hallucinogenic effects, and a whole range of psychoactive substances that people really aren't expecting and therefore can't prepare for. The consequence of all this volatility is that people really often have no idea what's in their drug supply. And we've seen research that shows that there can be up to 10 or more unknown additives in one stash. This can be really risky. This can lead to a lot of heightened and new risk for people who use drugs on top of the risk of an opioid overdose that we know about already. This includes some really kind of scary unanticipated reactions, severe wounds and infections, and then, of course, the overdose risk, which can be complicated with things like tranquilizers and make it more difficult to revive someone. People who use drugs often have no way of knowing what they're actually getting, and that makes it really difficult for them to sort of take the appropriate risk reduction measures. So that brings me to the innovation. The innovative solution here is this idea of community-based drug checking. So that is the use of technology that allows programs to help people test small amounts or small samples of their substance, in some cases right in the moment. And it can identify the composition and the potency. So that's sort of what are the active ingredients, what are the fillers or contaminants, and in what quantities or proportions. And that lets people make very informed assessments about the risk of use of that supply or that substance. And research shows, including some work that I've done myself with interviews with people who use drugs, that people will change their behavior in response to that knowledge. So, for example, if someone knows that there's something like xylazine or tranquilizer in their supply, they're much more likely to either get rid of that stash or use it more slowly, use less of it, use it in a safer route of administration, like sniffing rather than injecting, making sure there's naloxone on hand, and all sorts of other harm reduction responses. So drug testing or checking is a super valuable way to help people who use drugs be safer and reduce their risk. And it can be done in mobile units, like on a van or out in the community in the vicinity of where people are actually using.
So I think we have time for one more innovation.
Great. I know there's a lot of context to kind of make sense of these, but thank you for giving me the opportunity to explain them. One more innovation. I love this one. I think this is particularly novel as far as things we've seen coming out of the settlement landscape. But we frequently hear from representatives of smaller counties that are receiving very small payouts. This could be $20,000, $10,000. I've seen municipalities in some states receive a few $100s in a year. And these counties or municipalities often feel really frustrated and don't know what to do with such small sums because it might feel sort of useless or ineffective to put such a small amount towards an intervention if you can't really afford much with it. So the innovation that we've seen is that many counties have begun to pool their investments, basically combine their funds across county or city lines to be able to more effectively invest in costly expenses that actually span the region as opposed to just the county. This is a super collaborative and strategic approach and allows these communities to invest in targeted interventions that can address the issues specific to their region.
Can you give us an example of one of these projects?
Yes, absolutely. In our event, we had a speaker from Countryside Public Health. This is a 5-county, fully integrated local public health organization in southwest rural Minnesota, so some small counties, but they pooled their settlement investments and have been able to afford prevention curriculum and educator that spans the scope of all 5 of those counties, and they have a settlement grant fund that spans their 5 counties as well, so they can decide as a collective how to invest their conglomeration or full composition of their funds and use that money to go back towards programs that reach all 5 of their catchment areas.
So the 3 examples that you've given, you've talked about treatment, with buprenorphine being given in the field. You've talked about harm reduction, meeting people where they're at using drugs, allowing them to check those drugs. And now you've talked about this community-specific prevention, like allowing people to solve the problems that they are seeing where they're seeing them. I would imagine that all of the most innovative use of funds that you've seen sort of ladder up to these and other principles that you mentioned are known to help with the opioid epidemic.
Yeah, thank you for drawing it back to the principles. So my team at Hopkins created this set of principles to guide evidence-based settlement fund spending. And the biggest key principle is using the money to save lives. So we always compare interventions and programs that are receiving settlement funds to our principles to see whether they align. And while we might get a chuckle out of some of the sillier things that are going towards beach balls and sunglasses, which is one that I didn't even mention, or whatever drug-free lollipops are, that is money that could be used to actually save lives. We have so much knowledge at this point about what programs do work that any money going towards programs not supported by, or at least grounded in some form of evidence, are actually perpetuating harm rather than abating harm.
Well, Abby Winiker, thank you so much for joining us and walking us through all of these examples. And people can find out more about you on your website, which we will list in the show notes. Thanks for joining us.
Thank you so much. It was a pleasure.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.